This may have the feel of a presentation rather than a webinar. However, my intention today, more than anything, is to open up the question that I've provocatively given as a title for the presentation, up for professional and academic debate, to start a conversation. As I say, I suspect that I may not be able to see the comments or questions in the chat or even raised hands on my screen. However, hopefully Katrina and Fiona can keep an eye on things, and I will make a conscious effort to create natural pauses as we go along. I want to start by making two statements. Firstly, that my involvement in community children's nursing, or children's community nursing, or community paediatric nursing stretches back almost 40 years, right back to 1985, when I was first appointed to the role of community children's child nurse, one of a team of 3 nurses based at Central Middlesex Hospital in Brent. And over the course of my time in community children's nursing, I've been a clinician, a team leader, manager, contributor to policy development, teacher, lecturer, curriculum planner, researcher. If you cut me, surely I will bleed the letters of the words community, children's and nurse. No. Secondly, as I've said on many occasions, there's no single model of community children's nursing. Indeed, there are perhaps as many different ways of doing community children's nursing as there are different CCN teams. So my first statement dates back to 1888, a statement from Catherine Wood, who was the lady superintendent at Great Ormond Street Hospital. I'm going to try and move something around my screen just a second, sorry. Who in 1888 said, "I commence by stating 2 propositions. First, that sick children require special nursing, and second, that sick children's nurses require special training." I'll come back to the year 1888 in a moment, but also wonder whether one of the reasons why this statement continues to be the subject of ongoing challenge is the use of the word that might be interpreted as having a particular meaning, special. For now, I'll leave that with you, but the notion that children's nurses consider themselves to be special has perhaps not done us any favours. Having said that, we are perhaps different. I'm going to give now a couple of incidents from my experience going back over the years. Back in 1985, in the office of the community children's nursing team at Central Middlesex, we'd received a referral overnight from Accident and Emergency Department for a little girl who had sustained a scald injury whilst on holiday with her parents camping in France. That day, it was our pleasure. We were hosting a lady called June Jolly, who was chair of the Community Health Council in Greenwich, and who wanted to find out about community children's nursing with a view to establishing a service locally. Anyway, I explained to June before we set out to visit this young lady that the way that things worked in Brent was that referrals would often come to us from the district nursing office or via A&E or via the ward, and that was the way things worked, and children were only ever seen by community children's nurses in Brent. So we set off onto the first visit, knocked on the door of the house, and a lady answered the door and said, "Oh, you're the nurse. The nurse is already here." And June and I went into the house and found a nurse dressed from top to toe in dark green, and I think she was probably an enrolled nurse, who was stood over a child who was screaming her head off. She was holding 2 pairs of plastic forceps in her hand, attempting to deroof a blister on the child's scald injury. And when I introduced myself as the community children's nurse, she promptly threw the plastic tweezers back onto the dressing field and said, explained to me that she had had a referral from the GP because the mum had contacted the GP to tell her that the little girl had scalded herself. And she promptly left the house. I sat with the mother. I suggested that we might give her daughter some paracetamol, a glass of orange juice, something to calm her down. And we sat with the mother for a good half an hour before I attempted to recommence doing the dressing. We didn't use plastic forceps. We were already gloved up by that stage. And although she continued to cry through the procedure, the changing of the dressing, I think her experience was very different in my hands to those of the enrolled nurse, who I suspect had not a great deal of experience of providing care for sick children. Second example I just wanted to give was from my experience working at Southbank as a lecturer in the community children's nursing team. I took it upon myself at the time, whenever we had CCN students, to make it my business to always go out and do clinical visits with the students. And I vividly remember going out with Pat, who was one of my students working in Islington, to visit one of her patients who had a cancer diagnosis. And I remember Pat going to me and she said, "Mark, I know you think this is a bit odd as a student asking you this, but have you read Harry Potter?" I said, "Well, yeah, I'm familiar with Harry Potter. I had two children. I'd read most of the stories." She said, "Because part of my care," she said, "I don't know whether you're going to be completely content with this. Part of my care with this child is to read a chapter from Harry Potter." And I said, "Absolutely, Pat. You read Harry Potter, and I'll sit with the mum and have a cup of tea." And for me, both of those stories tell a little bit of the story about what is different about what community children's nurses do compared to what other nurses might do. So, in the days before community children's nursing, in the mid 19th century, hospital was not a place that children attended. Very few children were ever admitted to hospital. Very large numbers of children died in London, and children were almost considered expendable. Better off staying at home with their mothers when they were seriously ill, because being in hospital was not a place for children to be. Many of you will be familiar with Charles West, the medical doctor who was instrumental in the establishment of Great Ormond Street Hospital. But establishing a hospital for children in London was not an easy task. He wanted to set up a hospital. He drew together a committee supported by members of the local community in London, including Charles Dickens, and eventually that work led to the establishment of Great Ormond Street back in 1852. A picture some of you may be familiar with of the children's ward back in the building that was Great Ormond Street back in the day. And here, picture of Queen's Square. I think some of this architecture still exists, but round the corner from there, Great Ormond Street Hospital, a very different facade to that from the 1840s. Great Ormond Street was very popular from the start. Large numbers of children were admitted, and before too very long, questions began to be asked of the possibility of providing the expertise that Great Ormond Street was beginning to establish for itself elsewhere than within the hospital walls at Great Ormond Street. Charles West and Catherine Wood, who I mentioned earlier, proposed to the hospital almoners the development of a private domiciliary nursing service, which was intended to provide nursing care for children in home and also to improve the experience of nurses in training. The proposal was not supported at the time by the hospital at all. The lay members decided and were unanimously opposed to the extension of the work of the hospital into the community. However, by 1888, a private domiciliary nursing service was established based at Great Ormond Street, staffed by nurses who had completed at least 3 years of training in medical and surgical care. In a hospital of no less than 60 beds was the rule at the time. Training in tracheostomy care was particularly important because of the significant numbers of children who were recovering from diphtheria and had a tracheostomy as part of their treatment. But other conditions were supported by nurses in the community at the time, including orthopedic problems, post-operative care, and acute care. And I just want to put a little bit of emphasis at this point in the presentation webinar that right at the very beginning of the journey, community children's nurses were playing a key role in keeping children out of hospital by offering their nursing expertise to children who were acutely unwell at home. Tongue-in-cheek joke there, but I can imagine there would have been some sort of arrangements for the private domiciliary service nurses to meet. However, the Great Ormond Street established a large service. By 1938, 30 nurses were employed by GOSH within the service, providing full-time care for children. Often these nurses were living in with the families at home, providing care for them. And this was a paid-for arrangement. The paid-for community outreach nurses allowed the hospital to extend its work and subsidise its work to providing free care for families who couldn't afford to pay for care in hospital. And the work of the nurses was not restricted to children living in London. The archives, which I had the privilege of accessing, included details of a nurse from Great Ormond Street who was seconded for 6 months to spend time looking after a princess in Ethiopia before coming back and rejoining the service. Nice work if you can get it. Great Ormond Street wasn't unique in this regard. Several of the children's hospitals that were established across the UK in the years that followed and led up to the formation of the NHS also developed their own community outreach nursing services. So from Sheffield and in Birmingham, services were established, not as large as Great Ormond Street, but some of them were successful and some of them only lasted a few years. Again, all of these services seem to have provided a support for children who are acutely unwell at home. Excuse me. And managing the symptoms, or perhaps supporting the parents in managing the symptoms during episodic illnesses like measles, whooping cough, German measles, scarlet fever, and diarrheal illnesses, all of which were significant killers of children in this period and beyond, prior to and in advance of the introduction of the NHS, the widespread availability of antibiotics, and the rollout of universal vaccination programs. Early CCNs, by virtue of the work they were doing with children in the community who were acutely unwell, probably saved a significant number of children's lives. Okay, I'm happy to take a pause and any comments or questions, Katrina or Fiona.
There's nothing in the chat box yet, Mark.
Okay, thanks very much. I hopefully we'll have time for a bit of a debate at the end. But by all means, do put questions in the chat as we go along. Now, as we all know, and I think it's an important thing to note, the Register for Children's Nurses was established in 1919 at the same time as the Register for General Nurses. And so we were already established very early on that a children's nurse was legitimate. And I know that there have been and continue to be debates which have played out amongst colleagues in recent years about the development of a more generic pre-registration training. However, I think it is important that we don't lose sight of history. And the fact of the matter is that we've had registered children's nurses now for 105 years and more. So, as the NHS was introduced in the 1940s, we began to see the introduction of community children's nursing teams. And through the next few slides, I'll focus on a couple of aspects of that. One is the one that I've highlighted red here, that in Rotherham, a single Queen's nursing sister was appointed who'd undertaken a postgraduate course which covered children's diseases. It isn't clear from the account whether this nurse was a registered children's nurse, but there's no reason to think that she might not have been. The reason for establishing this service was because of a high rate of infant mortality in Rotherham as a result of a particularly cold winter, and there'd been significant growth in hospital deaths arising from cross-infection on the children's wards. So keeping children out of hospital who were acutely unwell was seen in this service as being important. And infectious diseases, pneumonia, bronchitis, measles and gastroenteritis were in large part the work of the nurse in this service. And this avoided unnecessary hospitalisation and was highlighted as a major benefit of the service. In Birmingham in 1954, 2 district nurses who were introduced as the CCNs who'd undertaken an orientation programme caring for children at Birmingham Children's Hospital. And again, this service focused upon children who are acutely unwell, trying to avoid children being admitted to hospital in the first instance or facilitate early discharge. Providing the service to these parents during the daytime and supporting them during the early evening meant that there were very few calls during the night. And in the early years of this service, it was very clear that the main referral source into this was from general practitioners. 92% of referrals in 1973, reducing as the service became established, with a closer association with the Children's Hospital in Birmingham. And in Paddington, the Paddington Home Care team, where I had the pleasure of working myself, the team was established and included 3 nurses with paediatric training. It was a unique collaboration in Paddington between GPs, paediatricians and community children's nurses. And for many years, that service had a paediatric registrar as part of the service. In the first 10 years of operation, 64% of the referrals from GPs, and of almost 2,500 children who were nursed at home by the service, only a very small proportion was subsequently admitted to hospital. Again, another service that focused on children who were acutely unwell, with gastrointestinal predominantly, and infectious and contagious diseases. So these early schemes came to the attention of the Platt Committee, responsible, as many of you will be aware, of the welfare of children in hospital. And although the Platt report was focused upon the welfare of children within hospital, they made a number of comments about the small number of community children's nursing schemes that were established at that time, recommending that children should not be admitted to hospital if it can be avoided, and special nursing facilities for children, looking after children at home, should be extended. What's interesting to me about the Platt report, as more than anything, is that not a single community children's nursing service was established in the 10 years that followed. And it does flag up that although we often get very major policy initiatives, and certainly there were very significant changes in the welfare of children in hospital as a result of the Platt report, we didn't see another CCN service introduced until the services in Edinburgh, which focused upon both children who were acutely unwell and children with orthopaedic problems, which was established in 1969. And again, a district nursing sister trained as a children's nurse was part of this service, which reported within a very short time of establishing the service, large numbers of children being visited at home by the community children's nursing service. And we also saw in 1969 in Southampton a service, 2 registered children's nurses who were also Queen's District nurses, working to support the establishment of a regional paediatric surgical centre. 10 years after Platt report, with Bowlby's and Robertson's work informing us that whatever we do, we should keep children out of hospital, we were beginning to see major inroads, and children who had historically spent between 1 and 3 and sometimes 5 nights in hospital and other centres were being managed on a day surgical list at Southampton in 1969. And by the early 1980s, the service was running to support 10 surgical lists per week across a wide range of surgical specialties. So in 1988, I had the privilege of undertaking a survey of CCN provision in England. And at that time, there were 23 CCN services employing a total of 45 nurses, though 11 of these services were a single nurse working on her own or his own. 44 of the 45 staff were registered as sick children's nurses. Almost all of them were registered as general nurses or state registered nurses as well. There was 1 enrolled nurse, I think, working in Doncaster. 22 of the staff, about half of the staff, were qualified as district nurses, and a couple as health visitors, and 1 held both DN and HB certificates. Very different time to now, but only 2 of the nurses held degrees. Many of the nurses who became CCNs then had worked as sister grade staff in the local hospital prior to moving into the community. And it was my absolute pleasure this was part of my MSc. It was funded by the ABPN through the Portex Scholarship, together with a grant from the Wellington Foundation. And I had the absolute pleasure of visiting, I could never do it now, but every single CCN service in England in the space of about 4 weeks. And the funding also helped to pay for printing costs and return postage to send survey questionnaires to each of the children's hospitals or children's units within DGHs within England, asking managers in those paediatric services if they had any intention of establishing a CCN team. This graph shows, and some of you who've listened to presentations I've done in the past, this graph illustrates the dramatic change in community children's nursing provision that happened from the beginning of the mid 1980s. perhaps entirely coincidental, with the fact that I'd done a national census about CCN service. Though my the questionnaire that went out alongside the survey, alongside the interviews, achieved a 97% response rate. And I also sent out to each of the people who responded and the 6 who didn't complete the questionnaires a 6-page summary of the findings just to pique their interest. But I remember vividly at the time that CCN conferences or paediatric community nursing conferences that were hosted by the fledgling community paediatric nurses special interest group at the RCN were incredibly popular, with really strong interest from nurses and managers who didn't have CCN services locally and were keen to set them up. And in addition, I mentioned June Jolly visiting us from Greenwich, but in addition, barely a week went by when our CCN team at Central Middlesex was not hosting one or more visitors, keen to find out what we were doing and how they might develop a service in their area. And colleagues such as Peggy Gow in Southampton, Peggy Keating in Manchester, Anna Saidi in Kettering, Julie Muir in Oxford, Sue Dryden in Nottingham, colleagues were when we came together as the special interest group at the RCN, colleagues would be saying to us, we spend all our life taking people out who want to find out about community children's nursing. Well, this graph shows the value of us having done that. Absolutely fantastic that between 1989 and 99 we saw almost 100 new CCN services established across the UK. And now the slides stop moving. Oh, maybe not. So I'm going to turn now to the matter of CCN education. In 1991, the UKCC, I've already mentioned that in the survey that I've done, there were 50% of the service, the staff in the services were either qualified as DNs or health visitors. Up until this time, there was no specific education programme to learn to become a community children's nurse. Anyway, in 1991, the UKCC drafted proposals for the future of community education, but in the drafting of that document, they failed to identify the need for a specific pathway to address the needs of sick children in the community. Well, the RCN, the Association of British Paediatric Nurses, Actions for Sick Children, and others made representation to UKCC, as a result of which a pathway for CCN education was included in the standards that were produced finally by the UKCC in 1994. Though I have to say, the standards as they were written at the time were largely a cut and paste of those that had already been pre-written for district nursing and health visiting. And these formed the basis, however, for the development of the CCN specialist practitioner qualification, those programmes being hosted by a number of the UK universities. The UKCC standards, as many of you will be aware, were subsequently formally adopted by the NMC. However, from the outset, many CCNs considered that the standards that had been written for specialist practice and education were obsolete. Almost at the point of publication, we were arguing for an updating to the standards. In spite of this, and in spite of multiple overtures by district nurses, CCNs and others to the NMC, it took till 2022 for the NMC to actually update and to publish the generic standards of proficiency, both for community nursing and for community public health, specialist community public health nursing. In the meantime, the QNI had developed a set of voluntary standards for community children's nursing, which were adopted by quite a number of the universities. And in the last couple of years, the QNI have produced a set of field-specific standards which have been clearly endorsed by the NMC and which are now being taken up by higher education institutions across the country in relatively small numbers still, but hopefully a growing number of HEIs will take on the CCN qualification in the years to come. But to be fair, uptake of the specialist practitioner qualification programme has been pretty inconsistent. There's a somewhat haphazard geographical distribution of programmes, making them inaccessible to students in many parts of the UK. Having said that, post-COVID, a number of the HEIs have developed programmes which have got a significant proportion of online and virtual attendance elements, so don't require the students to attend. But if your nearest university offering a programme is 80 or 90 miles away, it's still a challenge. And in addition, you've got to be seconded to do the programme. A lot of NHS commissioners are still only inconsistently supporting the programmes. And to be fair, I would say that some teams and the managers within them teams do have a strong belief in the value of specialist qualification and others do not. There are some teams around the country where nearly every member of the service holds a community children's nursing qualification, and there'll be a team just down the road in the next big city or the next part of the country where nobody has the qualification at all. We actually did see, following the publication of the standards in 1994, quite a significant number of CCNs have undertaken the programme. Having said that, getting the information out of the NMC was not an easy task. And although I've never updated the data set, I'm pretty confident in my belief that between 2008 and 2024, the number of students completing CCN's programmes was nowhere near this level. At one stage, we only had 3 universities actually running the programme, with only 13 students registered at those universities. It will be interesting to see, and I look forward to seeing whether the NMC and Q&I are able to reverse the trends as a result of the new standards that we've got. And I'll take a pause for breath. Fiona, any questions?
No questions. I suspect everybody's waiting till the end, Mark, to when you're going to challenge people.
Oh, that's fine. No problem whatsoever. Thank you, Fiona. Okay, so what do CCNs actually do? What do we do? Is it different than what other community nurses do? In the late 1990s, as part of the evaluation of Project 2000, the English National Board commissioned 2 of its research highlights, was specifically focused on elements of the CCN role in the context of pre-registration student experience. And I have to say that pre-registration student experience varies tremendously. Some students manage to get, and still do manage to get, placements with community children's nursing teams. Not all students on pre-registration programmes have that pleasure. It varies considerably across the country. Projects undertaken by Keith Cash and colleagues, and by Proctor and colleagues, both funded by the ENB, and both based upon conversations with CCNs, with parents and with pre-registration students, identified the things that community children's nurses do. And they included having technical skills and formal knowledge. And I think that has now moved on. And in the context of the Q&I and the NMC standards, what we're largely talking about, the stuff that CCNs bring to the table, is advanced practice skills. And for many, that will include skills in physical examination, in making diagnoses, and in prescribing. And certainly that skill set is one that I think will be increasingly required of the CCN in the future. Community children's nurses are very practical people. And what they bring to families is practical help, including skills for managing their own workload. Networking, coordinating, and advocacy skills. CCNs are people, very good relationships with hospital consultants, community consultants, very good at making things happen because they develop good networks and get to know how the systems work. In order to be a children's nurse, you need to have a finely developed skill set in interpersonal and psychological and support skills, both in terms of your engagement with children and in terms of your engagement with parents. Teaching skills. My perspective on this is that there are very few things that I've ever done to a child, with a child, as a CCN, that I wouldn't be prepared to consider teaching a parent to do if they were inclined to want to do so. Though for some reason, quite a lot of parents find passing a nasogastric tube a bit of a step too far. But with appropriate training, competency assessment, ongoing support, parents can be and have been and are regularly taught how to access central lines to take bloods or to administer medicines, how to change a tracheostomy tube in an emergency or a planned tube change, how to manage peritoneal dialysis at home. Increasingly, we're seeing parents who are being taught how to be able to make changes to a range of the settings on a ventilator. replacing a gastrostomy tube, accessing a mitrophanol. I'm sure that many on the call will be able to give examples from their own practice of things that they've taught parents to do. And passing on those skills is a key part of what we do. We also have thinking skills, thinking outside the box, doing things differently. I think that having worked in most recent years alongside colleagues in district nursing, and being involved in policy development and policy support at a senior level in a trust, I've seen district nursing services coming forward towards to get approval for practice guidelines to be introduced in the district nursing service. And I'm thinking, we were doing this 20 or 25 years ago in community children's nursing. I don't understand why you don't have a policy for this already in your district nursing service. I didn't say that too loud to my district nursing colleagues, I must confess. So who are the children that CCNs actually practice their art with? This document, I'm sure, will be familiar to many of you, and some of you will have been involved in the work that led to its production in 2011. It's the most recent detailed Department of Health document on the subject. So what do CCNs do? We care for children who are acute and short-term conditions, children with long-term conditions, children with disabilities, including those who have continuing care and neonates, and children with life-threatening and life-threatening illness. They're the groups of children predominantly who CCNs see. But that leaves a gap. We do see children with learning disabilities. We do see children with autism spectrum disorder, and we do see children with mental ill health, but only if they also fit into one of the 4 bullet points above. In large part, we don't provide a CCN service in most parts of the country for these children. And I'll come back to challenge about these 3 latter groups later, but in large part, community children's nursing is not providing for these groups of children. So it is a bit of a bugbear of mine, and I'll come back to it a bit later on, but children who are acutely ill. So in 2010, there were 20.6 million emergency department attendances in England. A quarter of these were infants, children and young people. On the news today, the number of A&E attendances nationally across all ages has increased by 6% year on year from last year. And for children, 6 conditions accounted for over 420,000 hospital admissions in 2008-2009. It cost an awful lot of money for these children to be admitted to hospital. But the significant majority of CCN teams actually see very few of children who are acutely unwell. Sorry. More and more children are attending A&E every year, COVID notwithstanding, and we did see a dip in both number of admissions and number of A&E attendances in 2000 and 2001. But the recently republished Darcy report, published since the introduction of the new government, noted more children are attending A&E, but the emergency admission rate is not increasing, suggesting that they didn't need to go to A&E in the first place in many instances. They could be cared for elsewhere. But the fact that they are attending is clearly creating a problem. More than 100,000 infants waited longer than 6 hours to be seen in an A&E department. In the 65 years since the Platt report was published, we've seen more and more children attending A&E each year. More and more children are admitted to hospital, often staying for less than 36 hours. And in spite of the massive and continuing growth in CCN provision, children born in 2004 are more than 3 times as likely to attend A&E in the first year of their life, and almost 3 times as likely to be admitted to hospital than were their contemporaries born in 1959. And this is despite the fact that we've got widespread use of antibiotics and massive immunisation programmes, which mean that children no longer have and experience the illnesses that they did in 1959. Though the anti-vaxxers are trying to do something about that. It isn't just me saying this. Here's a graph from the RCPCH from their 2018 publication. This is their estimates of children's attendances to hospital. This was published pre-COVID, but I have no reason to believe that these graphs, with a slight bit for 2020-21, that these graphs will change at all. More and more children attending A&E each year, particularly the very young children on this line here. and more children being admitted to hospital each year. Again, predominantly children under the age of 1 being admitted to hospital for stays of less than 24 hours. So, moving on rapidly, otherwise we'll have no time for questions. So, children with long-term conditions. The Department of Health identified a number of roles for children, for CCNs here, to improve the management of long-term conditions, to educate children and families in order for them to be able to improve their self-care, to teach families how to recognise early signs of exacerbation and deterioration of long-standing illness, with a particular focus on epilepsy, asthma and diabetes. But we know that these three particular conditions account for upwards of 90% of all readmissions to hospital of children with a pre-existing condition. Epilepsy, asthma and diabetes are not being as well managed in the community as they might be, and CCNs potentially have a very significant role to play in this regard. One area that we do see CCNs working is in the setting up of nurse-led clinics, and certainly we see this for children with asthma and diabetes and for eczema, and hopefully increasingly for children with other long-term conditions. But if CCNs are to be able to deliver this, they've got to be able to show that they're experts in care, that they have the knowledge and skills that are required to underpin that care, that their work can significantly impact upon children being admitted to hospital. And having said that, if I laid a graph of if I overlaid the two graphs of the increase in CCN provision and the numbers of children being admitted to hospital, you would find them both going, unfortunately, in the same direction. When I would very much like to see the number of children being admitted to hospital going down as a direct result of CCNs playing a greater role in the lives of those children. And we ought to be seeing for the children with long-term conditions. And I think we do see improvements in short and long-term outcomes, but I think there is a massive job of work still to be done. Disabilities and complex care conditions are bread and butter for many CCN teams. The Department of Health work recognises this and says that by enabling care at home, CCNs can reduce the length of stay and the cost of care for children with disabilities. There needs to be very strong governance and arrangements in place to supervise carers and support workers who are providing complex packages of care, particularly in the context of continuing care, but where we are delegating care both to parents and to other professional staff, we need to make sure that we're doing that correctly. I won't get to talk as much as I'd like to, perhaps, about the lead professional role, but the lead professional role is a crucial one. And I think CCNs are ideally qualified to take on this lead professional role when caring for children. Neonatal care clearly is also a very important aspect of care, and we do see significant numbers of children going home early from special care baby units supported by CCN teams, and in some areas by dedicated community neonatal services. But we don't know as much as we might do about children with about the numbers of children out there with complex health needs, particularly those who are technology dependent. And the latest work that was undertaken in this area was over 25 years ago. There's nothing as detailed as the work that was done by Glendinning and colleagues. But 25 years ago, we knew that there were 2,500 children receiving artificial feeding, 1,000 children with tracheostomies at home, 1,000 children who were having IV infusions at home, 150 on PD, over 1,000 on home oxygen. And at the time of that survey in 1999, there were 93 children on long-term ventilation. As an illustration of how that data is out of date, only a few short years later, work that was done by Colin Wallace and colleagues found that there were already almost 1,000 children on long-term home ventilation, almost 10 times the number that had been identified 10 years previously. But I say the received wisdom is that numbers of all of these children is growing, but the data is not as good as it might be. Just briefly now to turn to children with life-threatening and life-limiting illness. This group of children does receive a great deal of attention, and I think that community children's nurses do a fantastic job at keeping children at home with life-threatening illness. But sadly, we know that around 4,000 children die each year in the UK. 50% of these are of conditions that are likely to have required palliative care, but still, sadly, this was from the 2011 document, and I think figures will have improved, a significant proportion of deaths take place in hospital rather than at home, even when children and families express a preference for going home. 74% of palliative care deaths in 2011 were still in hospital. And we know that for every child who dies, there are approximately 10 others who are living with a life-limiting condition at any one time. And community children's nurses are often very heavily involved with these children. Pause for breath again. Fiona, any questions?
Yeah, there is. Kath Evans, are you still on the line?
I am indeed still on the line. Yes, Fiona.
Do you want to ask your points or raise your points? We may need to come back to them at the end, but do raise your points now.
Thanks ever so much, Fiona. And importantly, Mark, your organisational memory is absolutely phenomenal. And I think it's been incredibly helpful to actually hear, the significant history. I had a couple of reflections really in terms of opportunities going forward. One of which is, does the Children's Wellbeing Bill provide us with an opportunity? Are we actually connected in bringing together DFE and Department for Health and Social Care to make sure that community services for children are actually in there and embedded? How about the role of integrated neighbourhood teams? Again, is the presence and contribution of children's community nursing services recognised and part of those ongoing developments and conversations as that policy moves forward as well? And my third reflection was around the role of integrated care systems and integrated care boards and place-based partnerships. Are they really understanding the contribution of children's community nursing services, and how do we maximise that moving forward? So 3 elements: children's wellbeing bill, integrated neighbourhood teams and ICBs. Any thoughts would be appreciated.
Okay. I'll come back perhaps to talk about, I think one of the challenges is although the number of people working within community children's nursing teams has grown significantly, and Kath, you and I are both from Hertfordshire. In my 1988 study, there were, I think, 54 CCNs 45 CCNs in the whole of England. We almost have that many CCNs in Hertfordshire now. However, what those teams still do not seem to have the capacity to do is to get engaged in that strategic work, whether it's with the local partnerships or the ICBs or whoever. It's freeing up the capacity with the people who've got the real knowledge of community children's nursing to be able to get involved in that strategic planning is the challenge. And it does happen locally in some areas, but not all the teams are as large as those that we thankfully have in Hertfordshire now. There are still teams of only 1 or 2 nurses in some parts of the country, and they spend their lives delivering clinical care and can't get involved in those bigger conversations. But we'll come back to it. Okay, so just to summarise what CCNs actually do, what we actually do is provide expert clinical care to children in the context generally of a physical healthcare need. We offer practical advice for children and their families, including problem solving and troubleshooting issues related to clinical care. We coordinate care, sometimes the formal key worker or lead professional, including advocating for and networking on behalf of families. And I think we do that very well. And I think we are very fortunate, still in the world of children's nursing, to work with paediatricians who get it. In adult nursing, that isn't always the case. But in children's nursing, we generally are working with paediatricians who we can have a serious grown-up adult conversation with and not feel patronised within that relationship. Empowering children and families to promote independence and self-sufficiency, to take responsibility for their own care. And for children with long-term conditions, I think that's particularly important. We provide teaching and training for children, their parents and other carers. We provide equipment, electrical equipment, disposable supplies, continence products, items sometimes not available on GP prescription, and CCNs are very good at finding creative ways of resolving that. Providing emotional and psychological support to children and their families. the critical understanding of child development and the focus upon family care as being central to children's care are key things that CCNs do brilliantly. And we also promote health and prevent ill health, primarily in the context of the child's long-term condition or complex health need or disability. But more generally, I hope that we do make every contact count, and we are taking every opportunity to promote health with children. What else do we do? Particularly in palliative care, symptom care, including the management of complex medication regimes, working alongside GPs, paediatricians, specialist palliative care doctors. CCNs play a fantastic role here. Absolutely brilliant. One of my colleagues, Mary Heffernan, I take my hat off. So I couldn't do what she does, but the work she does is just absolutely brilliant. Out of hours care. Most community children's nursing services do not work 24 hours a day, other than in the context of out of hours care or some continuing care. But many services do step up. Many CCNs will step into 24-hour care at the end of life for families. Emotional and psychological support, as I've mentioned, and counselling and support for siblings. But here he is, our old friend, the elephant in the room. Is the skill set that's required by children and families exclusively one that can only be delivered by a registered children's nurse who's undertaken a post-registration programme in community nursing? Well, the answer is clearly no to that. I reckon that no more than a third of the CCNs around the country have got a CCN qualification. And that, in my view, is potentially a problem. Could somebody else do our job? Well, a nursing associate. We're developing very interesting conversations about the physician associate today, but the nursing associate role is also one that presents some challenges. Could a nursing associate do our job? A nursing auxiliary? Could somebody other than a registered nurse working within our team do what we do? Could a district nurse do it? In those areas of the country which have very small or in some instances still no community children's nurses available at weekends or out of hours, could the district nurse provide the care? What about the practice nurse? An awful lot of practice-based care of children is delivered by the general practice nurse. The vast majority of asthma support for children within general practice is delivered by an adult trained practice nurse and not by a CCN. A hospital nurse. Well, we're not keeping these children out in the community as we might do, so perhaps the hospital nurse may be better equipped to provide the care. Maybe a social worker. A parent, or maybe grandma. Look, if I can find the button to press. Yes. Lots of people can do what we do, perhaps. Do we really need a community children's nurse to do all these things? And what about those children I mentioned earlier? Learning disability nursing is predominantly adult learning disability nursing. Children with learning disabilities do not get, for example, any adult with a learning disability is entitled to an annual examination by their general practitioner. You're not entitled to that as a child. So who could do that? Learning disability nurses do not see many children in the community. Autism spectrum disorder and mental health problems. CCN teams do see children in small numbers, but not many. And I don't think we're doing any favours. And my personal bugbear, and the one thing I would challenge CCN teams to think about, why on earth are we not making major inroads into reducing the number of children who attend A&E each year or who are being admitted for conditions that our CCN predecessors seem perfectly happy to care for at home? We still have a service that is predominantly operating 9 to 5, and a significant proportion of children who attend A&E do not attend between 9 and 5. They attend in the early evenings and are admitted to hospital because the SHO F1 who is seeing them doesn't have the confidence, and the parent isn't happy to take them home overnight. And we don't have a CCN service that would potentially look after them. Well, to return to my original question, do we really need CCNs at all? Well, I've got a very strong answer to that. Yes, we do. But I think we've got a job of work still to do to convince the rest of the world that we do.
Okay, Mark, there's been a number of points that have just come onto the chat box.
Okay.
The first from Sarah Neal is, we now live in it's a great overview. We now live in a digital world. How do you see digital healthcare helping to solve some of the problems you have highlighted?
Okay, I certainly think we could make very significant use of video triaging, video conversations with parents. Certainly, I give an example from a piece of work that I was doing of a mother that I visited in Scotland who had used her own telephone to do a video call with another mother to help her to troubleshoot a blocked gastrostomy tube. And I think we don't necessarily need to be at home with the families to do that. We can do an awful lot using video technology. I'll throw that out there as one example.
Okay, that's great. I'll do a few more from the chat box, and then I'll go to somebody who's raised their hand. Hospital at home is the way forward. Shame commissioning local to me have no funding for this whatsoever, despite acknowledging that it is the way forward. CCNs, however, I feel should be a separate service alongside the hospital at home teams. The other big problem is we don't actually have the numbers of staff to fill all these ideas. Any thoughts, Mark?
Oh, absolutely. One thing I would say, when I came into post as a consultant nurse in Hertfordshire in 2004, we had 4 hospital sites across the county where we had inpatient paediatric beds. We had the Lister and Welwyn Garden City in the east of the county, and Watford and Hemel Hempstead in the west of the county. We now, alongside having really robust community children's nursing teams, we only have 2 sites where we have inpatient paediatric beds. So it is possible to consolidate paediatric beds, and it is possible to free up the money that generates to support the development of services in the community. And it does require people to be brave and to say, right, we are going to do this, and we're going to support reducing the number of beds, which will save money by developing the service in the community.
Okay, I'm
Fiona,
going to.
can I just suggest, it's Katrina. We've
All
got
right.
a number of different points
4 minutes left.
Yeah, and we've got a number of points. Only 4 minutes. We've got somebody with their hand up. It's
Yeah.
a real shame to lose any of these points. So if people are happy, then what we can do is share these with Mark and have an exchange and answer of all of the points, because I think there's some really useful comments that we've seen, and it's a shame that we don't get you. I don't think we're going to have enough time before we lose the call, Mark. So just a promise that we will pick up on.
Yeah,
all
absolutely.
of the
And I'm very happy to pick up.
Yeah.
Thanks.
And we do need people to let us know if they're interested in being involved in work being taken forward. I'm not sure who has put the hand up.
It's Caroline
Carol.
Reeve.
Carol.